What I want to talk about is to lead off the conference by talking about evidence-based practices in child and adolescent mental health and why they're important. Why are evidence-based practices important? For many people in the room, you've heard the term, in fact, almost everyone's heard the term, evidence-based practice these days. 10 years ago, it was something that was discussed primarily among academics who were doing research on child mental health or adolescent mental health or medicine or education, any one of a number of disciplines. And there's been so much resurgence, so much development of interest in evidence-based practices, and now most people in educational settings and in mental health settings and in non-mental health medical settings have heard about evidence-based practices. The reason that evidence-based practices are important is implicit in the definition evidence-based. It means that the practices, in our case, treatments and interventions and preventive interventions for childhood and adolescent mental health disorders, are based on systematic research, scientific research. And that's very important, not based on anecdote, not based only on experience. Experience is important, but based on systematic research. It has always surprised me that there's been some degree of controversy about evidence-based practices, especially in community mental health settings, because it's evident in every aspect of our lives in other disciplines. So how many people in here have a regular physician that you go to for checkups and to get medical care? Everybody, right? I assume that you, like I do, assume that when I go to my doctor and he or she gives me advice about what to do, that they're giving me advice based on scientific knowledge, not just what they thought of when I happen to walk in the door, or what their next door neighbor told them they should do the night before, or an experience with a patient 10 years ago, but that they know the scientific literature, that they're regularly attending continuing education programs, which are required for physicians more than they are for mental health professionals, and that they know the literature, and that when he tells me that I should or shouldn't be taking a given pill or doing a given medical regimen, I trust that my doctor is using an evidence-based practice. That is, he knows the scientific literature, he's learned that somehow, and he's telling me things that the science shows works. The same in education. How many people have kids? Raise your hand if you have kids. So this was a rude awakening to me. My children are now college age, high school and college age. When they started out, this was 18 or so years ago, before evidence-based practices had taken root in either the field of mental health or the field of education, I found myself asking their teachers why they were doing some of the things that they were doing, and some of the academic interventions that the kids were doing, and some of the other things they were doing in the classroom, and I would get blank stares back. And I'd talk to the principal and say, well, I was wondering what the scientific evidence behind, what does the educational literature shows about this approach to teaching reading or math that you folks are using with in Will's kindergarten class, for example. I think we have always expected that our teachers of our children, and the principals who run the schools, and the administrators who run the schools, know what the science shows about education, and that they're using scientifically based educational approaches. That's all what we expect. That's what we all expect. Even in industry, in fact, probably most prominently in industry, there are practices that are based in systematic study that show how one should or shouldn't put a car together, for example. How many people in here own a car that was built by their next door neighbor? No one does. How many people own a car that was built by one person whom they happen to know who builds cars for a hobby? Nobody does that. We buy cars from manufacturers that use a whole catalog of evidence-based approaches, scientific-based approaches to develop their automobiles, to build them, and to sell them. So everywhere in life, evidence-based or scientific practices are implemented. We all are so used to those that we don't ever think about them. They're what we should be emphasizing in mental health, in what we do every day on a daily basis, just like we expect from our doctors, just like we expect from our children's teachers, just like we expect when we buy a newfangled computer or a new car, that they're developed according to systematic study and scientific principles. So in 2000, Hillary Clinton, when Bill Clinton was the president, Hillary Clinton established a national conference, or had a national conference that the Surgeon General ran, that was a national action agenda for children's mental health. There were lots of concerns at the time, actually, about over-reliance on the use of medication with very young children. That's what led to this conference. And it identified a number of goals that should be implemented over the next decade for improving children's mental health, promoting the recognition of mental health as an essential part of child health, integrating family, child, and youth-centered mental health services into all systems, engaging families and incorporating the perspective of children and youth, developing and enhancing a public-private health infrastructure to support these efforts, and so forth. These were the main goals that came out of that conference, was attended by a very large number of people, experts from all sorts of disciplines in Washington, D.C. These are the sub-goals of the conference, and I've highlighted in yellow the word scientifically proven or high quality to show you that that was presumed at the conference. It was presumed that everything that was going to be developed, that all of the emphases that were going to take place over the next decade in child and adolescent mental health were based on science, based on scientifically proven investigations, scientifically proven treatments that have been developed and studied systematically. So that was the presumption that that would be done. So this was 10 years ago. 10 years ago, the Surgeon General established this for the agenda for child mental health over the next decade, and it was presumed that everything that happened in that would be evidence-based. Why is there such a strong emphasis on scientifically proven, or why was there on scientifically proven evidence-based practices in that initiative? I have a good friend who's on the faculty at Florida State University, and he's fond of saying, what is the alternative? Do you want interventions that are not based on science? Do you want interventions that scientific studies have shown don't work? Well, of course not. We want things that science shows works. There is no alternative to that. Chuck Cunningham, who's one of the presenters at this conference, has actually done a study showing that when you do consumer preference modeling studies with parents, so you ask parents what kinds of preferences they have for the services their children will receive in a mental health setting, one of the most important things to parents is they say they want to know that whatever they're receiving has been shown to work in good, scientific, well-controlled studies. That was a surprise to Chuck, a surprise to me, to know that regular parents whose children are seeking mental health services, they want things that are based on scientific evidence. So how are we currently doing? Do EBPs, evidence-based practices, work better than treatment as usual? This slide actually just shows the increase in the number of scientific citations from one of Kimberly Hoagwood's papers on the number of references to evidence-based practices, evidence-based treatment, and evidence-based medicine. And as you can see, starting in 1995, there was an explosion of mentions in the scientific literature. So this has been happening particularly for evidence-based medicine first, and then evidence-based practice and evidence-based treatment next for mental health. How are we currently doing? Unfortunately, it is still the case that the vast majority of interventions that are offered in the child and adolescent mental health field in community settings is not evidence-based, meaning it's not one of the interventions. The interventions being used most commonly are not the interventions that the scientific studies have shown are most useful. Current practices often are not effective and sometimes even harmful. How many of you read the article, 7 or 8 years ago now, about the therapist in Colorado who was doing rebirthing therapy with the child, where you wrap the child in a blanket and hold them very tightly, and they're supposed to re-experience their birth. That was actually for several years a very popular intervention until the child died from suffocation using the intervention. So people think of things, they're well-intentioned, they think that they're going to help, but they're not based on scientific studies, and sometimes they have very bad outcomes. There are two very well-known studies in the mental health field, the Fort Bragg study and the Stark County study, conducted by another one of our speakers here today, Lynn Bickman. And these studies essentially looked at whether or not if we really improved the system of care, if we improved the way care was delivered in a mental health setting, we improve the system of care, would that improve the outcomes for children? So if we make sure that kids all get a good assessment and that assessment provides information about what should be done in treatment, and then the children get connected with the provider in the treatment setting, and we make sure that whole system works well, is that going to result in better outcomes for children? These were huge studies, cost hundreds of millions of dollars when they were done, which was 20 or 30 years ago, and they showed that no, actually having a better system of care didn't make any difference. And Lynn's conclusion at the time was, this was before evidence-based practices were widely used. His conclusion was, well, if you make a good system of care, but people aren't doing practices that have scientific evidence, then it won't make any difference for the children. We'll have a better system of care, but the outcomes for the kids won't be any better. So doing more or having a better system of care of what we currently do is not the trick. Now, since people started paying attention to evidence-based practices, scientific studies, a number of faculty members, a number of scientists have looked at whether or not evidence-based practices do in fact do a better job than what's done in community care. Do they do a better job than treatment as usual? There are a number of studies, I'll show you some slides, showing that in fact evidence-based practices, carefully studied scientific practices, do better than routine care. And in fact, so much so that evidence-based practices are emphasized in the new National Healthcare Affordable Care Act, also known as Obamacare. There are large incentives built into the healthcare system over the coming years for implementing evidence-based practices. Before describing what this means, or what evidence-based practices are, I wanted to tell you a bit about effect size. For academics, for people who are used to doing research, this is common knowledge. But if you're in a community mental health setting, you might not know what effect size is. Effect size really is an index of how big the impact of a treatment is for what we're talking about. And you develop an effect size by taking the average score of your treatment group, the average gains in an intervention group, and subtracting out the average gains in whatever your control group is. So if we're talking about a test of a new intervention, you take the effect or the size of the gains in your new intervention and you compare it to whatever your control group is. The control group might be people that were on a waiting list, or people that got some other kind of intervention that you thought would control for contact, for example, but not provide the key elements of the intervention that you're studying. And then divide that by a measure of variability or standard deviation. And in scientific studies, there are guidelines for interpreting effect sizes. These have been around for quite a while. 0.2 change is a small effect size, 0.5 is a medium effect, 0.8 is a large effect. In the field of psychology, it's very difficult to get large effects. So we live in a setting in which small effects sometimes are good. We like to have larger than 0.2. Medium effects are very good, and effects of 0.8 or higher are very hard to get. Anything that's, I would say, in the range of 0.4 and higher means that we've got something there. We've got an important finding. This is just another way of looking at it from one of John Weis's graphs. Large, medium, and small effect sizes and the degree of beneficial effect. If you have an effect size of 0, then you have no effect. That means that there was no difference between the control group and the treatment group. So an effect size of 0 means nothing happened. If you have an effect size of less than 0, a minus effect size, it means actually the intervention was worse than doing nothing. So you definitely don't want something with a minus effect size. So John Weis, more than anyone else, has done studies where he's looked at the entire literature and compared the studies of evidence-based practices to various treatment as usual conditions. And these are a number of reviews. If we look for our purposes just at the right-hand side of this graph, we're talking about interventions for children and adolescents here. Those are studies that have examined the impact of a variety of different types of interventions for evidence-based practices. From the Casey and Berman, I think, is 1985, I believe. going all the way up to 2011. And as you can see, given what I told you a minute ago about the size of effect sizes, the average effect size of interventions for evidence-based practices are pretty good. In 2011, John reported that the difference between the intervention and the control conditions ranged from 0.46 to 0.6. So remember, that's a medium to large effect size. It's a very solid effect size. How good is that? If you take child and adolescent mental health, 0.6 effect size on the far right. Is that your right too? Yes, on the far right, effect size of 0.6. John compares these to effect sizes for organ rejection intervention, cyclosporin, for treatment for AIDS, and also for aspirin. How many people in here take a baby aspirin every day to prevent heart attack? I'm 2 people. Only 2 people? Whoa, okay. You all should be doing this. Although you might say, yeah, but the effect size is tiny. Effect size is tiny, but that's enough, a big enough effect size for the federal government to say everybody over 40 should be taking a baby aspirin every day because it prevents, lowers your risk for heart attacks. So the point of this slide is that even though it's hard for us in the mental health field to get good effect sizes, and we think we take a second-class seat relative to medicine, this effect size is pretty good for some of the more important areas of medicine. Another point is if we do evidence-based practices, do the effects last? And John has actually analyzed from a number of studies whether or not the evidence-based treatment effects last. And as you can see, over time, number of weeks following treatment, the effects do decrease. So I showed this slide as a point of saying that anytime you're doing intervention for a child mental health disorder, you have to keep in mind that whatever you do acutely is in all likelihood going to dissipate unless you build in maintenance of some type. So you build in follow-up sessions, you build in booster sessions, you build in phone calls to the parents to keep things going. So the effects do last somewhat, and they last for quite a while, but they do tend to dissipate. So we need to think about many childhood mental health problems as chronic conditions where we need to do initial treatments and then figure out some way to maintain the effects of those interventions over time. So the point of this is that John Weis's work has showed that evidence-based practices do in fact work better than usual care provided in mental health settings. So how are evidence-based practices defined? Some common features of evidence-based practices are these. They're extensively studied, their effectiveness has been documented, they're listed in a variety of professional association or other reputable guidelines, and I'll show you a list following this. They're generally based on behavioral, cognitive behavioral, or behavioral family frameworks. They typically have a manual that goes along with them, because if you're doing a scientific study of an intervention, you have to be able to replicate it, so whoever's doing the intervention has to write down what they do so that you can then give that intervention to somebody else. They can read the manual and then do whatever the initial developers did. So you have to have treatment manuals. Typically, these focus on clearly described behaviors that are targeted for change, and they focus on reducing impairments, building adaptive skills, and improving functional outcomes. They typically do not focus on decreasing the DSM symptoms of disorders. So most evidence-based practices focus on changing the problems in daily life function that the individual is exhibiting, not on decreasing the number of DSM symptoms. That's a very important thing to keep in mind. They typically involve parents and teachers as implementers or facilitators of treatment, and they use not only psychiatrists and doctoral level psychologists, but MA, BA, paraprofessional clinicians, and group treatments as in addition to individual treatments to reduce costs and to maximize transportability to the community mental health system where there aren't a lot of psychiatrists providing services who are available to provide services, not a lot of money to pay people at that level. They often employ a functional analytic approach to develop and monitor and modify the intervention as necessary. It's very important to emphasize to have initial effectiveness and to maintain treatments. that you implement an intervention in a systematic way, you monitor the effects of what you're doing, and then you modify what you do in treatment based on the effects of monitoring. And Lynn Bickman is going to be giving a talk on Friday about the importance of monitoring in regular community care and then adapting treatment based on the results of monitoring. And then finally, as I mentioned, because we know that the effects don't always last, include procedures for generalization, for maintenance, and then for relapse prevention. Everybody in the substance abuse field knows what relapse prevention means, because for 30 years we've known that you can effectively eliminate substance problems in many people by putting them in a locked unit. You can't drink alcohol if you're in a locked unit with no access to it, but the key in the substance abuse field is, okay, when the person gets out, how do you prevent them from relapsing? That's a concept that over the last 15 years people have started to talk about more with mental health as opposed to just substance use interventions. If we get a child in a good state after we do an evidence-based practice, then how do we prevent relapse from occurring? So you have to build in procedures for that. So these are some of the common features of evidence-based practices and evidence-based treatment across a variety of disorders. So one of the interesting things about evidence-based practices is 10 years ago, it was not hard for you to find a list of what evidence-based practices were, because there were very few of them. So you could go to the NREP list of SAMHSA, for example, the National Registry of Evidence-Based Programs and Practices, and a couple of other places, and get a list that would say, okay, these are the evidence-based interventions. Now everybody has a list of evidence-based interventions. The NREP list is one of the most prominent. The Institute of Education Sciences has one for education, the IES. That's called the What Works Clearinghouse. If you're in an educational setting, I encourage you to go to the What Works Clearinghouse. You just type that into Google, you'll get to it, and look at their list of what practices are evidence-based in educational settings. Many professional organizations have lists of evidence-based practices. ACAP is the American Academy of Child and Adolescent Psychiatry. They have lists, and they also have periodic reports on what's evidence-based for a given disorder, what treatments work for a given disorder. The American Academy of Pediatrics does the same thing in any disorder that are commonly used in pediatric settings. The American Psychological Association has information about evidence-based practices and produces reports on that. National Association of School Psychologists, Blueprints in Violence Prevention, which you can find on the web. There are reviews in journals all the time of what works, and I'll talk about later the reviews that are in the Journal of Clinical Child and Adolescent Psychology, and the list of treatments that the Society for Clinical Child and Adolescent Psychology have developed. That's the group that's helping to co-sponsor this conference. And there's Cochrane Collaborative and other places where people do reviews. Now, one of the puzzling things is that the specific interventions that are on any one of these lists might be slightly different from the interventions on another list. There are lots of similarities among them, but there's some differences. And some of the differences are that different lists or different teams of people use slightly different criteria for what is or isn't evidence-based. For example, this paper in 2003 graded the scientific evidence for a number of prevention interventions, and they had 7 levels of evidence they accepted. And they evaluated interventions and assigned scores based on the degree to which they had really tight evidence, the highest being multiple RCTs, that is a randomized clinical trial, a control study, where subjects are randomized to get one intervention or not. And that was done by 2 or more independent teams and had evidence of effectiveness. That is, it could be implemented in a real-world setting, not just in a controlled scientific clinic setting or academic clinical setting. So that's one way to look at evidence-based practices. The American Psychological Association approach, the one that the Child Clinical Group has used, is 2 well-conducted group design studies conducted by different investigators, in which the intervention is shown to be superior to a pill or placebo or an alternative treatment, or equivalent to an established treatment, already established treatment. Now, this criterion, which is probably the most commonly used among evidence-based practice reviews, came from the FDA criteria for these criteria. It came from the FDA criteria for approving a new medication. To get a new medication approved in the FDA, you have to have at least 2 studies, randomized or otherwise tightly controlled studies, in which you show that the intervention is better than a control condition or at least as good as a medication that's already been approved. So that's where the initial criteria came from for the task forces in the 1990s that did this, from the FDA criteria for getting medication approved. Okay, these are just criteria for different types of interventions. So if you apply these criteria for ADHD and conduct problems, 2 very common problems of childhood, what do you find tends to work? Typically, evidence-based practice reviews show that behavioral parent training is effective, classroom behavior modification is effective, and then a variety of child-focused behavioral and cognitive behavioral treatments for peer problems done in school settings or after-school settings or summer settings are effective. So interventions that involve teaching the parents how to work with the children, interventions that involve classroom, teachers implementing things in the classroom, and child-focused interventions. What do these lists typically show for anxiety and depression? That cognitive behavioral treatment, cognitive behavioral interventions, which involve either teaching cognitive skills or behavioral skills to children who are depressed or anxious, or providing exposure to feared situations for children who are anxious, sometimes involving parents, sometimes not involving parents, are evidence-based interventions for anxiety and depression. In 2008, the Society for the Science of Child and Adolescent Psychology did a 10-year update of what was published in 1998 that were reviews of evidence-based practices, and essentially said there was a lot more evidence on the sorts of things that I just listed here. Solid evidence for a number of good practices in child and adolescent mental health. Now this shows something slightly different. So if you're going to do, how many people in the room here have run parent training groups? Just raise your hand if you've seen. So a lot of people have run parent training groups. You use a manual, and the manual has a number of sessions that you're supposed to use to teach the parents parenting skills that they can apply in the home setting to help their children to exhibit better parent management practices and to help their children improve their behavior. There might be 10 to 15 sessions in those parent training programs, with each session perhaps teaching parents a different skill that they are to implement. In interventions for child anxiety, for example, I mentioned earlier that exposure, figuring out some way to expose the child to the feared situation, is an important element of interventions. Typically, teaching improved cognitive skills is an important element of the intervention. Well, Bruce Chorpita, for a number of years, has been saying one of the interesting things about evidence-based practices is we're emphasizing having a manual and getting your whole manual and your treatment described, and then implementing that manual as it exists with the child. And he said for some time, maybe there are common elements inside of these manuals that we could pull out, and we don't have to do the whole thing. So maybe we don't have to do 16 sessions of parent training with everybody. Maybe if we could target what a parent's particular problems are, we could get away with doing fewer of those. Or maybe if we could find out for a child who seems to be anxious exactly what his problems are by doing a very careful assessment, we could match the child's problems with an intervention that wouldn't take as long as doing 16 sessions of Coping Cat, which is Phil Kendall's excellent intervention for anxiety disorders. So he's gone through thousands of studies and looked at thousands of studies on evidence-based practices and psychological interventions and said, what are the common elements? How often did these things show up in the studies of child anxiety, for example? And as you can see, the most common one was exposure. The second most common was relaxation, teaching the child relaxation skills and so forth. Then if you go all the way down to the bottom, things that didn't show up very often in studies that showed an effect were play therapy and catharsis. So Chorpita would say, don't do play therapy and catharsis if you're trying to teach a child with an anxiety problem how not to have anxiety. Focus instead on exposure and relaxation. You can do the same thing for depression. So Chorpita's looked at what the common practice elements are for depression, the common practice elements for ADHD, the common practice elements for delinquency and conduct problems. This is a very long list. So actually it's divided into high frequency and low frequency. And again, you can see that, let's see, individual therapy for caregiver, guided imagery, exposure, those don't have much evidence base. They're not used very often in the studies that are effective for conduct problems. However, timeout praise, tangible rewards, problem solving, psychoeducational intervention for the parents, those are the interventions that do occur frequently in the interventions that work for delinquency and conduct problems. And then the same for autism. I reviewed earlier what the evidence-based practices, what some of the common features of evidence-based practices are. If you're talking just about psychosocial treatments for conduct problems, parent training, school intervention, and child intervention are important evidence-based treatments. These slides are going to be in your packet, but I'm going to skip these for now. And for internalizing problems, I showed you what Chorpita said, so we'll skip these. And then I want to show you what Chorpita has done, given his focus on trying to tease out what the effective elements are in practices. He and John Weis have a program where they say, well, if we can figure out what the child's problem is and we can identify a specific component of an evidence-based practice that might work on that, can we come up with a more efficient way of delivering services? So they do a very careful assessment of a child. Actually, they've done the work that I showed earlier, identifying effective practices. So for CBT, for anxiety and trauma, these are the effective components. These are what they came up with from reviewing lots of studies. For CBT, for depression, this is what they came up with. And then for behavioral parent training conduct problems, these are what they came up with. So this is a different way of showing you the same thing that I showed in the slides about effective elements. And then they have a decision tree where you start with an assessment of a child, you figure out what the primary problem is, then you enter a child, a therapist would do this, enter the child into the particular types of classes of interventions that are important. You can't see this, but you'll see it on the slides that are printed. Essentially, it's a stepwise procedure to saying, okay, this child has a general problem in anxiety. So what are the specific components of his problem? Let me look at that. Let me look at each specific component. And then there's an organized way of saying, if he has this, then the first thing you should do is, if he has X, the first thing you should do is Y. And then you check and see whether or not Y worked. If Y worked, then you take the next problem on the child's list and then implement treatment Z. And if that works, then you take the next one and so forth. If it doesn't work, then you loop back through and try something else. So it's a very systematic approach to looking at what might be effective without taking the entire package and implementing an entire package of 16 sessions with every child. Because you might find that after you do 3 sessions that are targeted to what that child's problems are, then things are better. So this is a different way of approaching evidence-based practices that's designed to try to make it more, make evidence-based practices more accessible to community mental health settings where there's not a lot of money to do lots of longer interventions. And this just shows, again, what some of the lists are for autism, some of the evidence-based practices for autism. So what I'm going to do for the rest of the time this morning is to talk about the place that I think is the best place for you to go to learn about what practices are evidence-based in child mental health, and that's the initiative developed by the Society for Clinical Child and Adolescent Psychology. So in 1998 and 2005 and 2008, this society did systematic reviews of what's evidence-based in interventions for childhood and adolescent mental health. And the 2005 was what's evidence-based in how you assess or evaluate children's mental health problems. 1998 and 2008 were what you do to treat children's mental health problems. This group has had conferences for the last 15 years and journal reports for the last 15 years about what seems to work in child mental health and adolescent mental health. And currently, over the last year actually, the division has been posting a lot of information about mental health services for children and adolescents on a website, effectivechildtherapy.com. So I want to describe this initiative and describe the website and show you what some of the information is, some of the places you can go to actually learn about what seems to be the latest state-of-the-art best practices for child and adolescent mental health. How many people have been to this website? Can I see a show of hands? So maybe about 15. How many people in here work in community settings or school settings? Raise your hand high if I can just see. Okay? Leave your hand up if you've been to this website. So not many people have been to the website. This is something that if I were working with kids in a community setting, I would more or less live with this website up on my computer because it has tons of useful information about what you can be doing, where you should be looking, about good practices for child mental health. So effectivechildtherapy.com. If you go to this website, the entry website, you'll find lots of written information about what practices work with families. And there's information for parents, and there's information for educators, and there's information for child and adolescent mental health professionals. effectivechildtherapy.com. And the information is designed to be ingestible in a short period of time. So these are not treatises on what evidence works. These are shortened, capsulized summaries of what seems to work for a particular type of problem. And for the parent information, it's written in parent-friendly language. For the professional information, it's written in language that a professional would understand, and the same for educators. What we have done to take the next step beyond written information and beyond reviews is to move into the web age and take a lot of the information and put it on the web in video format, because we know that most parents won't sit and read a 2 or 3 page handout about whether or not their child might have a mental health problem, but they would watch a 10-minute video about whether or not their child might have a mental health problem, and if they did, what they could do about it. And we know for professionals that also a lot of professionals don't read extensively. They don't read long papers in journals about evidence-based practices, but they will watch a video about an evidence-based practice. So the division gave FIU a grant 3 years ago to bring experts into town to give talks on what evidence-based practices were. And these experts were often the same people who'd written extensive literature reviews for the scientific arena about evidence-based practices, and have them give a talk and in a fashion that would be useful for frontline clinicians. There's co-funding for that from FIU and from the Children's Trust. So what we have is a series of internet streaming videos to provide exposure and training in a variety of evidence-based practices for child and adolescent mental health. We have it for parents. We have it for professionals, and we have it for educators. And I think it's self-evident. Why are we doing it on the internet? Because the internet's available everywhere. Anne Marie Albano, who is probably in the room someplace, hopefully, or will be by her workshop this afternoon, says that she wants us to film a commercial for the website that shows her sitting in her robe, having her morning coffee at breakfast with her feet up, watching a video saying, "Need CEUs?" And her point is that she would much rather get a CEU when she's drinking her morning coffee and watching a video than she would have to come to a conference like this. She's happy to present at a conference, but she would rather be staying at home watching a video for getting her own CEUs. So you have a lot of accessibility. We figured out that we can take the information and put it on the internet in a very user-friendly way. We can provide all the handouts that you usually get at a conference. You can have the PowerPoint slides to print out in advance before you watch the video. There's extensive references for people who want to do additional reading. So there's lots of information in the way it's been established. And perhaps most importantly, it's self-paced in that when you're watching a video on the web, if you miss something, you can go back and watch it again. So we know that, actually I don't know what the average attention span of the average adult who's a mental health professional is, but I would assume in the course of listening to a 60-minute talk that most people probably lose their focus of concentration 10 or 15 times, even if it's just for a moment. If it's just for a moment, you miss a little bit of what happened. If you're watching a video on the web, you can just back up and pick up what you missed earlier. So there's a lot of debate about whether or not watching something on the web would be as good as doing it live, and I think actually there's increasing evidence that it's better than doing it live because you can go backwards. And it's self-paced. One of the big things that we tried to do with this initiative, the underlined part at the bottom, it says generic as well as commercial modules. So one of the interesting things about evidence-based practices now is that a lot of the developers have, in order to increase adoption, have actually worked hard to market, to develop materials that are nice and user-friendly and can be marketed. And they form relationships with companies to market their products. So for some behavioral parent training programs now that are excellent programs that are on all the evidence-based program lists, it costs a fair amount of money as an agency to buy into one of the parenting programs. You have to buy all the materials, you have to buy all the training, and so forth. The division is trying to take generic versions of these based on the work that Bruce Torpeda has done, saying, well, we don't all have to pay $20,000 to have program X in our mental health center, if in fact we can do a generic version of that using what the literature says about which components are most important. So there are generic versions of many of the interventions that you have to buy otherwise that you can pick up on the Division 53 website. And all of the presenters on the website have agreed that if you look at something on the website and you want more contact with the person that did it or their group to learn about how to do what they did, you can call them up and make arrangements on your own to receive follow-up consultation, follow-up services. So the experts were all selected with knowledge of evidence-based practices. The speakers were all brought into FIU for a couple of days to be filmed in front of a live audience. How many people in this room went to one of those workshops at FIU over the last couple of years? Just raise your hand so we can see. Not that many. And those are continuing, those are all free. So if you watch for our FIU Speaker Series talks, you can go to participate in the workshops that are filmed. And most importantly for us, for trying to keep the cost down on this, most of the people who've been filmed have donated their time, including this conference. People have donated their time to come to the conference and are happy to have the division use the information. Because of that, we're able to offer most of the videos for free. So all of the parent videos are free. All of the keynote summaries are free, and I'll show you examples of those. What's not free right now are the workshops. The workshops are more detailed presentations of interventions that range in length from 2 hours to 12 hours to learn how to do a specific practice. This is what this is where you get if you go on the first website and you click online videos. It brings you to this website, which is the FIU online video website. And if you look at the top with the green green circle surrounding parent resources, if you're a parent and you click on that, then it takes you to a list of topics on which there is a 10 to 15 minute interview with an expert or professional conducted as an interview. So there's an interviewer interviewing the professional to ask about what a parent needs to know about this. And they're typically focused on asking the interviewer, ask the professional, tell me about anxiety problems in children. What does it look like if a child has an anxiety problem? How would you know if your child has an anxiety problem? And then after they talk about what the nature of the problem is, it's the questions are, well, if my child has a problem with anxiety, what kind of treatment should I be looking for? And the expert tells them. So you don't look for catharsis, for example, if you're talking about anxiety for kids. You look instead for somebody who's going to do cognitive behavioral interventions. So they're really nice, and they're very much in parent-focused language. They're all being translated now into Spanish, so they're available in both English and Spanish in the near future. And they're all these topics. Not just traditional disorder-based topics, but even topics like divorce and the impact of divorce on kids and what parents need to know about that and what kind of help they should seek for their child if they're going through a divorce. So there are lots of parent talks. They're all free. The keynote talks are done by the same people who are interviewed for the parent talks, and there's a whole host of these also on everything ranging from abuse to Tourette's syndrome and how to treat it, by well-known experts in the field. Some of these folks are here today to present at the conference, and again, for a whole range of topics. There are 20 some odd of these up, and another 10 or 15 are planned to be filmed over the next couple of years. Virtually everything you'd want to know about how to treat a child and adolescent mental health disorder for a professional is going to be up here, and it's all free. You can watch it for free. Now for the workshops, these are intensive experiences in how to do an evidence-based practice. So these are people who developed a specific practice, and they're doing a workshop, just like this afternoon your workshops will be, but typically longer than that. People exactly how to do it. Here are the workshops that are up already or that have been filmed already, and most of these are up on the web, and there are more that are scheduled for filming. I wanted to give you a sense of what one looks like. Good, so this is Kevin Stark doing a workshop on his intervention that can be done in school settings for children with depression. This is an example of what you will see.
So this activity came out of some school counselor book on like 101 counseling activities kind of thing. But then we changed it around to fit with the kind of cognitive model that we were trying to teach the kids. Okay. All right, so now what you want to do, or what would be helpful for the exercise, is if you take the bead and put it into your shoe or sandal. Okay, Karen was kind of like immediately grimacing as she gets the idea. Okay, and then go ahead and stand up. All right, so what do you notice? It's pretty unpleasant, right? Okay, so go ahead and take the Jolly Rancher and put that in your other shoe. No, I'm just kidding. Go ahead and start eating the Jolly Rancher. Okay, so what flavor did you choose? Blue raspberry. Good. How does it taste? Yeah? You can really notice the sweetness in it. And does it taste kind of like blue raspberry popsicles and all that? Yeah. Okay, good. So concentrate on the flavor. Good. So everybody really concentrate on that flavor? Got it? Okay. So when you're concentrating on the flavor, where does your mind go? To the flavor. What happens to the bead? The bead goes away. So if you really concentrate on the sweet things, the good things, even though you're having something bad happen, what happens to the bad thing that's happening? Goes away.
So that's an example of what you'll see if you go to one of these workshops. Kevin does an excellent workshop. It's, I think, a 10-hour workshop on how to learn his intervention and do it. It's a very inexpensive intervention to do that's got a lot of evidence, is very effective for working with children with depression.
Fabian, what we're going to do today is talk about your tics a little bit, and we're going to try to teach you a way to help manage your tics, how to control them a little bit, okay? So we've talked a little bit about a lot of the different tics that you're doing. Yeah. Can you tell me one of the...
So there's a really good they're not just academics, they're very good clinicians who developed interventions. So this is an example of a workshop. These are examples of workshops that are on the web. The difference between the keynotes and the workshops is that the workshops cost money. However, the cost is not very much. It's a price to be competitive with what it costs you for an hour of continuing education currently, and there are group discounts. So if you work in an agency and you want the whole agency to watch a given workshop, or you want the whole agency to watch a whole bunch of workshops to have access to the whole thing, they're very good prices that are far less expensive than it would cost your agency or your school to purchase 15 evidence-based interventions on the open market. So it's a very good way of finding out, not only finding out what's evidence-based, but in getting training in what's evidence-based in a very low-cost fashion. That's the goal of the division. So I've described the SCCAP video and web-based initiative on evidence-based practices. Now, before drawing a final conclusion, I want to spend a few minutes talking about moving evidence-based practices into the community. We've talked a lot about studies that have been done on evidence-based practices. Many of these, it's important to note, have been done in community settings, showing that, these practices can be done in regular clinical care settings by regular therapists working in the community. However, there are some barriers to effective implementation of evidence-based practices in the community, and I wanted to review just a few of those and some possible solutions to them before drawing final conclusions about evidence-based practices and their worth in child mental health. What are some of the barriers to implementation and some of the settings in which there are barriers? The barriers dealing with families, schools, mental health settings, primary care, community, and some state and national barriers. I'm going to focus primarily on barriers in mental health settings. One of them is lack of financial resources for children's mental health. It's often said that it's too expensive to do evidence-based practices, that some evidence-based interventions cost more than non-evidence-based interventions. Well, some people have argued that financial resources and the lack thereof is a barrier to implementing evidence-based practices. However, to the extent that evidence-based practices produce better outcomes in children, then they're more cost-effective. So we should be able to offer better services and more services to children at lower cost if we use evidence-based practices. In addition, if we move towards a paraprofessional and a master's level model of the sorts of clinicians that provide evidence-based practices in community settings, then most of the evidence-based practices we've talked about are developed for use by clinicians with those levels of training. And again, the cost of that is lower than the cost of some of the more traditional levels of service that are provided in mental health settings. The second barrier and solution is inadequate therapist knowledge and skills regarding evidence-based practices. One of the reasons for this is that training programs of mental health counselors, training programs for clinical psychologists, training programs for child psychiatrists, for example, all take a broad, eclectic approach rather than an approach that focused on evidence-based practices. We need to focus on evidence-based practices in our training programs from the beginning, so we teach our students that evidence-based practices is what they should be doing and why they should be doing them. We need to establish those as part of accreditation so that programs that don't teach evidence-based, scientifically based practices don't earn accreditation or lose accreditation. We need to define the absence of the use of these as unethical. Interestingly, the American Psychological Association has guidelines for the use of assessment and diagnostic batteries in children, and the guidelines are very tight. They say that people should not be using assessment devices that haven't been shown to work, and that people need to be trained to do those devices. However, very few people apply these sorts of rules, and we're talking about intervention. Therapists are giving too much latitude in terms of what they want to do. We need tighter control over what therapists do, and we should define therapists who don't do practices that have a scientific evidence base as unethical, in the same way that we define research as ethical or unethical. We need to establish alliances to bring other mental health disciplines that have not yet moved as much as the field of psychology has into evidence-based practices into the field of effective interventions. We need better control over continuing education programs. Again, using the American Psychological Association as an example, continuing education programs can be offered and can be accredited by the APA without providing any evidence that what they're teaching has an evidence base or is scientifically proven. Accrediting agencies need to have better control over that so that one can't earn continuing education credits unless it's been demonstrated that the intervention that's being taught is an effective, scientifically based intervention. And then finally, one could tie therapist pay to the use of evidence-based practices. We don't talk about that much in psychology, In the field of education, there's been a revolution in the past decade arguing that teacher pay should be tied to the effectiveness of their teaching. In many domains of society, pay is tied to the effectiveness of what you do. That hasn't happened in mental health, but perhaps it should. Then therapists would be motivated to find treatments that work if their pay was tied to actually having their clients improve. Another barrier is the conceptualization of treatment as brief and time-limited for many mental health disorders. Many mental health disorders are chronic. For example, ADHD, conduct problems, to a certain extent, depression. These are all disorders that don't just begin and go away in a short period of time. They may be with the child as they turn into adolescence and as they move into adulthood. So we need to establish models of treatment, models of intervention that look more like a primary care, chronic care model. If a child has asthma, for example, his pediatrician doesn't set up a 6-week plan to treat the child. The pediatrician instead talks with the families about a care model that's going to involve very long-term interventions and constant contact with the primary care physician. The same thing should be true of many mental health problems. And that means having a continuum of services, integrated services, and step care model of services. It also means that we emphasize outcomes rather than contact hours. And again, we can tie therapist pay to long-term outcomes. So we need to take a broader view of treatment for childhood disorders than just a problem that can be dealt with in 6 weeks, more of a long-term chronic care model approach. Another barrier solution is the traditional office-based, clinic-based approach to treatment with children. Mental health clinics are typically freestanding buildings where everyone who walks in the door is being treated for a mental health problem. They open at 8:30 in the morning and they close at 4:30 in the afternoon. These sorts of hours don't come close to approximating what families need to receive mental health services. Families need sessions, programs that are open on weekends, programs that are open at night, flexible programs, flexible kinds of interventions. They need programs that are offered in school settings, that may be offered in their own primary care doctor's offices, programs that are offered in community settings, whether it's community associations or churches. So we need to think about redesigning mental health clinics and just changing the entire way that clinics are offered. There are studies showing that parents would rather go, and in fact are more likely to attend, sessions that are taught in their child's school than in the local community mental health center. And then finally, as I mentioned, we need to improve the family friendliness of services by offering mental health interventions at times when parents can come, and by removing barriers that may be there for parents. So if we're running parent training sessions, if parents are coming to parenting sessions because one of their children has ADHD and they're learning better parenting practices, and they bring their ADHD child who's going to participate, for example, in social skills training while the parent is in parent training, for many parents, they're stuck with finding a babysitter for the rest of the children in the family. We should be offering babysitting services in mental health clinics so that parents can come, they can bring their child who's targeted for treatment, and both parents can come, and they can bring their other children and have them taken care of while they're in treatment. Another barrier and potential solution is the overemphasis that we have right now in the mental health system on diagnosis rather than treatment. The mental health system spends a great deal of money and a great deal of time deriving an initial DSM diagnosis for a child or adolescent with a mental health problem. The focus in intervention for mental health problems is not on changing diagnostic symptoms, it's instead altering the functional impairments that the individual has. So not changing the DSM symptoms, for example, in ADHD, that would be not worrying about inattention or impulsivity or hyperactivity, but instead focusing on the impact of those symptoms in real life functioning. That means focusing on the nature of a child's relationships with other children, the nature of his relationships with his parents, his functioning in the school setting. These are all areas of functional impairment. They're not DSM symptoms of disorders. That's what we need to focus on. That means the emphasis in initial assessment shouldn't be on making a DSM diagnosis. It should be instead on obtaining a good sense of what the child's problems are in daily life functioning and what the functional variables are that impact those areas of daily life dysfunction. That should set up what we want to do in treatment. So it's changing the nature of intakes and changing the nature of initial conceptualizations to focus on analyzing what the nature of the problem might be and treating it rather than making a diagnosis. Finally, lack of oversight and supervision of therapist activities has long been a major problem in the mental health field. Typically, people get degrees to be mental health practitioners and then never receive any oversight or supervision after that. They could practice in a mental health clinic for 10 years and never have anybody watch what they do, never have anyone check whether they've learned anything new, whether they're applying the correct evidence-based practices for whatever they're doing. We need mental health settings, we need laws, we need regulations that require that therapists use manualized treatments, that require that therapists use evidence-based practices, and that require justification for exceptions. In many medical center settings, there are algorithms, for example, for the kinds of interventions that a doctor must be prescribing for a patient with a given diagnosis. And if a doctor is going to deviate from the algorithm, they have to write a justification for it. If it's a doctor who's a junior doctor in training, he has to receive permission from his supervisor in order to deviate from the prescribed algorithmic service. We need to be doing the same thing in mental health. In addition to requiring justification for exceptions from the provider of the services, we need to provide written treatment consents to the families, to the parents in the case of most childhood disorders, that document therapeutic actions that deviate from standard practice so that clinicians can't make their own decisions that may deviate from standard practice without the family knowing that they are deviating, that they're not doing what's standard. And then finally, and perhaps most important, we need to adopt standardized progress monitoring programs throughout the field of childhood mental health. So that when a therapist is seeing a child, for example, or an adolescent, that they're constantly monitoring the progress using a standard instrument, and there are a number of those available, and using that monitoring to alter the nature of the intervention that they do. So they're constantly monitoring progress and then altering what they do based on the progress that the child is making and changing what they do if the child is not making progress. So if we make these sorts of changes, then we will be providing better oversight and supervision of therapist activities and increasing the likelihood that the interventions that they implement, if they're evidence-based, are going to be effective. So we've talked in this keynote today about evidence-based practices in mental health and why they're important, and about some barriers to implementing evidence-based practices in real-life settings in community mental health. Let me summarize what we've talked about by just saying that there's very little evidence that care as usual in the child mental health system is generally effective. So just doing the same old thing that the mental health clinician thinks is going to work isn't an effective intervention for most children with mental health problems. There's much evidence that a subset of interventions that have been done in practice that are identified as evidence-based through scientific studies of their impact are effective. They do represent effective interventions. That's what we need to be doing in the mental health field. Evidence-based practices have been shown to have substantial beneficial effects on children and adolescents compared to intervention as usual in community and school settings. There are many evidence-based practices available for child and adolescent mental health problems, and lists of them are widely available and they're widely accessible through many sources. I described for you earlier, for example, the web-based initiative of the Society for Child Clinical and Adolescent Psychology that's available at effectivechildtherapy.com. And there are others, for example, the SAMHSA REP list. There are a number of evidence-based guides, and those are what we should be using to pick the interventions that we're using in mental health settings. And finally, more widespread use of evidence-based practice would help achieve the goal that we all have in working in child mental health. That's to improve the mental health of the children and adolescents with whom we work. And finally, if your own child had a mental health problem, wouldn't you expect him or her to receive a scientifically validated evidence-based treatment? I would, and I think most of you agree, and shouldn't we be doing the same with our patients that we expect for our own children? Thank you for listening to the talk. Don't forget about the next Niagara in Miami conference in 2015, and please do check out the website at effectivechildtherapy.com. Thank you for coming today.